This is the lecture on Chapter 7, Diseases and Conditions of the Musculoskeletal System. In the first few pages of the chapter, there's a description of the system itself. Now, I have to assume that you already know about the musculoskeletal system through either an anatomy and physiology class or maybe you've taken the medical terminology with anatomy and physiology using the language of medicine. If you don't recall the details of the system, the anatomy and physiology, you should really go back and review the system to understand the normal before I begin talking about the abnormal. In the musculoskeletal system chapter, there's inclusion of conditions of muscles, bones, ligaments, tendons, cartilage, and joints. There's some wonderful illustrations of the muscles of the body. So as I refer to problems with particular muscles, you can certainly refer back to these first pages of the chapter. There's a good description of what the voluntary muscles are versus the involuntary. Descriptions of the bones and how the bones are also important in maintaining the homeostasis in the body because of maintaining the proper level of calcium. Hematopoiesis takes place in the center of the long bones and the bone marrow. That is blood production, hematopoiesis, where the blood cells are formed. We'll talk about the joints, the synovial joints, which are the movable joints, and we'll talk about conditions in which the patient has a reduced range of motion. If you are in the physical therapy assistant program, you will be concerned with helping patients to regain their range of motion so that they can truly use their joints and their limbs to full capacity. I provide this screen first to show you what you will not be tested on from Chapter 7. So you'll know that when we come to these conditions, you can skip over. Of course, they're very interesting, and you might want to read about them anyway, but as far as the test material in this class, I will not be covering these particular conditions from Chapter 7. Okay, moving on to what I will be covering in Chapter 7. The first condition is fibromyalgia. And if you remember much from medical terminology, which I sure hope you do, the algia is pain, the my is muscle, and fibro here refers to fibrous tissue. The fibromyalgia is a chronic pain condition associated with stiffness and tenderness affecting muscles, tendons, and joints throughout the body. When you read about the signs and symptoms, you find that a person often has difficulty sleeping, some depression, fatigue, anxiety, even bowel dysfunction goes along with the fibromyalgia, and certainly pain in certain areas. And I've shown on the PowerPoint screen some of these areas that the person may actually develop pain. There are 18 specific tender points. And a person that truly has fibromyalgia usually has pain in at least 11 of those 18 areas. The chronic pain is debilitating. It's kind of hard to diagnose also because the physician has to rule out other causes of the pain to decide if fibromyalgia is really the problem that the person is suffering from. There are blood tests that will show other conditions of the muscles, but there is no specific laboratory test or blood test to definitely diagnose fibromyalgia. So it's like they have to check to find out if the person has all these other conditions, and once they rule out those conditions, they know those are no longer a possibility, and the patient has this tenderness and pain of at least 11 of these 18 tender points, and they have the other signs and symptoms that go along with it, the conditions of not being able to sleep and anxiety, depression, again, the bowel dysfunction, then the physician may conclude that they have fibromyalgia. They don't really know about the cause. There's questions about stress causing fibromyalgia, trauma, chemical imbalance, or even infection triggering the fibromyalgia. No treatment as far as a cure, but treatments are given to relieve the symptoms. Non-steroid anti-inflammatory drugs, and sometimes steroid also. Muscle relaxants may be helpful, stress reduction techniques. And the patient education is also very important in that if the patient understands their disease, the more they can understand it, the more likely they will be able to deal with it and keep exercising, taking the antidepressants, doing all of the things recommended by the physician. Okay, other disorders of the system. Lordosis is an exaggerated inward curvature of the spine. It's commonly called a swayback condition. If you look at the pictures here on the screen, the normal spine does have a lower curvature at the lumbar area. When a patient has lordosis, that lumbar curve, like I said, the word exaggerated, it's truly curved to the point that the person is looking like they're holding their back further back, their shoulders further back. Now, when you look at the conditions that may result in lordosis, you understand that better. When a person gains a lot of weight, especially in the abdominal area, then they'll kind of walk with their shoulders further back, and it kind of bends their spine a little further in this swayback condition. Also, when a person's pregnant, they will, once they get really pregnant, like 8 and 9 months pregnant, they will begin to walk kind of sway back. And I love the treatment here. The treatment is, if they're pregnant, they'll deliver the baby. Usually resolves the condition. Now, if they're obese, if they've gained the weight in the abdominal area and they have this sway back condition, of course, weight loss is the treatment there. There are a few other causes of lordosis, and sometimes it's especially noted in girls before puberty because they have such a rapid skeletal growth, and they don't really have the stretching of the tissues that's necessary for a normal spinal position. And osteoporosis may also result in the lordosis. So the treatment is kind of directed at whatever the cause is. And there are times also where a person may have ruptured lumbar disc because of the lordosis. Braces may be used, of course, physical therapy. And there are some surgeries that can be used also to correct the lordosis. Again, the treatment is directed at the cause. Okay, now kyphosis, which is just the opposite. When a person has kyphosis, they're in a bent forward position. They have a humpback. And if you'll look at the picture that I have on the screen, that's I guess the best description is the picture there. Kyphosis. Now, the most common cause of kyphosis will be osteoporosis in an elderly person. Because of the breakdown of the vertebrae, they'll begin to have this humped over position. Some of the other etiologies for kyphosis in very young children, when they develop this humpback condition, there's some developmental problem there in the development of the spine. There is an adolescent form of kyphosis. It's a degeneration, deformity of the thoracic vertebrae. A person may also develop kyphosis because of tumors or tuberculosis of the vertebral bodies. ankylosing spondylitis. Collapse of the vertebrae from weakened bone of osteoporosis, again, is the most common cause, and it's most common in postmenopausal women. The treatment of kyphosis itself, bracing, is going to be important. Exercises to strengthen the muscles and ligaments, and trying to determine the underlying cause. If this is occurring in a postmenopausal woman, then the appropriate drugs to control osteoporosis may be used. And I'll be talking about osteoporosis in just a few minutes. And then scoliosis. Scoliosis is a lateral or sideways curvature of the spine, and the pictures on the screen really tell the story here. When a person has scoliosis, it's usually congenital. It's usually a condition that they're born with. This is a condition that your children or you have been screened for in the schools, where the school nurse will come and kind of just check to see if the spinal column is straight or not. Because if they can identify this early, in the early childhood, then the braces can be used, the exercises can be used. Treatment is much easier when the person is still developing than after they reach adulthood. And again, the treatment kind of depends on what's causing the curve. It depends on the extent of the scoliosis. And there are surgeries that can be done also where rods are actually placed in to straighten the vertebrae. Osteoarthritis, such a common condition of inflammation of the bones. I said inflammation of the bones, I'm sorry. Inflammation of the joints and the bones. Osteoarthritis. Itis is inflammation, osteus bone, arthros the joint. Also called degenerative joint disease. DJD is a pretty common abbreviation. There's degeneration and loss of joint cartilage, and then atrophy of the adjacent bone. Atrophy, the bone just kind of deteriorates there. Great picture here showing the normal joint and the joint of someone that has osteoarthritis with the eroded cartilage there. And I'll come to the rheumatoid arthritis in just a few minutes. The picture's given there of the rheumatoid also. Certainly the person's going to have pain of the joints, soreness of the joints. And it just develops as a part of the normal wear and tear on the joints. People over the age of 75, all of them will have some degree of osteoarthritis, whether it's just in one joint or in multiple. It's more common, it's going to be in multiple joints. Occurs mainly in the larger weight-bearing joints, the weight-bearing joints, the knees, the hips. And as far as the treatment of osteoarthritis, it cannot be cured. It's about trying to reduce the inflammation with anti-inflammatory drugs, physical therapy, even nutritional management. Surgery could be used in very severe cases. The joints can be replaced, the knee joints can be replaced, the hip joints can be replaced, but that's kind of a last effort. Certainly the person wants to try to control these problems, this inflammation, before it's necessary to have a total hip replacement or a total knee replacement. For those of you that are planning to go into the physical therapy program, you'll be teaching the patient about range of motion exercises. Alternating moist heat and cold applications often will relieve some of the symptoms. Massage therapy, bandages, splints, just for support of the joint. And I mentioned the drug therapy. Analgesics are just pain drugs to relieve pain, muscle relaxants. The NSAIDs, that stands for non-steroidal anti-inflammatory drugs. Those are drugs that work against inflammation, but they're not steroids. And I mentioned the joint replacements, which would be an arthroplasty. And an arthroplasty, an artificial joint is inserted. Artificial part put in the body is called a prosthesis. It says arthroplasty with joint prosthesis insertion is necessary in some cases. Okay, now I want to talk about Lyme disease, and I have these pictures on your screen because Lyme disease is actually transmitted by the bite of a deer tick that is infected with this specific bacteria. And a person that spends more time in the woods is certainly more likely to have ticks on them and be bit by ticks that may transmit the bacteria. Caused by a spirochete, that's a type of bacteria transmitted to humans by a bite from a small tick. Signs and symptoms include a bullseye rash. This is a very distinctive rash where it's very red in the middle, and it gets lighter and pinker as it goes outward, and as the redness spreads outwards, it just becomes more and more pale. The rash will be there, and the rash will actually move from one area of the body to the other. You can see this kind of on the person's back shoulder, and it may disappear from there and then reappear on their abdomen or reappear on their leg. So they start out with the bullseye rash, and then they start having the signs and symptoms of infection, maybe feeling like they have a flu, headache, fever, fatigue, joint pain. If the Lyme disease goes untreated or not recognized, the person may develop neurologic abnormalities or even myocardial abnormalities, problems with their heart because of this infection. It's called Lyme's disease because of where it was first identified in around 1975 in a little town called Lyme, Connecticut. And it's certainly more prevalent in the northeast part of the United States, in the New York, New Jersey, Connecticut area. You can see from the map on your screen the number of reported cases of Lyme disease in 1997, and you can certainly see that they are mostly there in the northeast United States. Sometimes it may take the physician a little while to actually diagnose this because the muscle aches that go along with it can be mistaken for other conditions. If a patient gives a good history of being in an area that's likely infected by these ticks, infested by these ticks, and if they can give the good history of having that bullseye rash, then it certainly makes it much easier to diagnose this condition. There is a blood test that can be done to identify the antibodies to Lyme disease and even directly identify the bacterium in the infected skin if a biopsy was performed. Oops, let me back up there. I didn't mean to go forward. Okay, the therapy for Lyme disease. Antibiotic therapy is necessary at whatever stage, the very earliest stage of infection, and certainly it's going to be more effective in preventing the neurological and myocardial problems the earlier the treatment begins. But the antibiotic therapy, specific antibiotic therapy, is necessary in all stages. And then physical therapy is helpful to help the person regain their mobility. Okay, now bursitis, which is inflammation of a bursa. The bursa are these fluid-filled sacs that contain synovial fluid. They're located between muscles and tendons, and these sacs often cover over bony prominences like the elbow area, the shoulder. When a person has the inflammation of the bursa, of course it's going to be painful, and it's going to be difficult to move that joint just because of the pain there. The most common joints affected by the bursitis would be the shoulder, the elbow, the knee, the hip. The bursitis of the elbow is actually called tennis elbow, and the person may never have played tennis in their life, but it will be referred to as tennis elbow when they have bursitis of the elbow. There's also bursitis of the knee that's called housemaid's knee, as if someone were on their knees scrubbing the floor, but again, you may not have ever scrubbed the floor, but have the severe inflammation of the bursa, very painful, may be present, and it's housemaid's knee. Very distinctive point tenderness is present. Instead of the person like rubbing their whole arm, saying my arm hurts, it's very specific. They can point to exactly where the pain is, and that helps the doctor to realize that it's very localized in a bursa. So it's usually a pretty straightforward diagnosis. MRIs can be performed that will show the enlargement of the bursa. And if it's really severe, the fluid can be aspirated from the bursa, but it's usually better to take more conservative approach towards the treatment with rest of the affected area, with anti-inflammatory drugs, maybe even cortisone shots, which would be the steroid injections. So the non-steroid anti-inflammatory drugs, those are drugs like ibuprofen, brand name Advil, Motrin. The steroids a person actually needs a prescription to take steroid anti-inflammatory drugs. The cortisones are steroids, and a person may actually receive a cortisone injection into the area to reduce inflammation. They say the cortisone injections are very painful in the area, but sometimes it's necessary because the pain of the bursitis is so severe that the person has lost their range of motion. And again, physical therapy can help them regain that range of motion. Osteomyelitis. Very serious infection and inflammation of bone and bone marrow. Now, when you say itis, it means inflammation. And in the case of osteomyelitis, that inflammation is due to some infectious bacteria. It's usually staphylococcal bacteria. And the staphylococcal bacteria have infected bone and bone marrow, causing a very severe inflammation, painful. Now, the infected area may have an open wound near it, where like a cut on the leg, an open wound of the leg, and they get the wound infected with staph bacteria, and it may work all the way down into the bone and into the bone marrow. Or there may not even be an open wound in the area. It may have come from an infection somewhere else on the skin. It could come from a throat infection. Could travel from any area that the person has infection and travel into their bone and bone marrow, causing this severe inflammation. In children, it usually occurs near the epiphyseal plate at the long end of the bone. The epiphyseal plate is actually the area that the bones grow from. It's the growth plate. So it causes very severe problems with development and growth of the child when it occurs at the epiphyseal plate. In adults, most commonly occurs in the spinal column. And it causes deterioration and breakdown of the bone, where the person may actually be permanently crippled by this process. Signs and symptoms: pain, of course, at the area that's affected. Signs of systemic infection throughout the body: chills, fever, sweating, tenderness on and around the affected bone. If the infection progresses and abscesses form, the abscesses may actually lead to sequestrum, which is death of the bone tissue. And then the person may have to have surgery to remove this dead bone tissue. Very, very serious condition here. And again, the staff is responsible for about 90% of the cases, though they may also have a strep infection that spreads to the bone and bone marrow. People who are more likely to develop the osteomyelitis are people who have had joint replacements, people who have diabetes mellitus, sickle cell disease, and certain cancers. Certainly to diagnose this, the signs and symptoms and the pain, and if the person has history of having a joint replacement, the physician's going to be thinking more likely towards the osteomyelitis. Cultures can be taken. In cultures, a sample of tissue is removed from the body and looked at in the lab and under the microscope to identify bacteria being present there. MRIs can be used in CAT scans, imaging techniques to allow the physician to actually see the progression of the disease and decide if there's actually sequestrum present there. Surgical drainage may be necessary. And again, surgical removal of that dead bone. Hyperbaric oxygen treatments may also prove beneficial. That is just a super saturation of oxygen to the area that really makes a difference to healing. Okay, the next condition is gout, chronic hereditary disease of uric acid metabolism. So, it runs in families. It's a problem with the way uric acid is changed chemically in the body. The person will have a buildup of uric acid in a particular joint, and it is usually the big toe. Now, it can be in the ankle, it can be in other joints of the body, but it is usually the big toe. Severe pain. And they'll also have signs of systemic problems there with the fever, the chills, the headache, nausea going along with it. I've got pictures of certain foods here. A person that eats and drinks these particular foods are more likely to have attacks of gout. If gout runs in their family, they've got that hereditary tendency towards it. Foods like red wines, certain cheeses, fish oils, all contribute to that buildup of the uric acid. Treatment is rest and immobilization of the affected area. Again, anti-inflammatory drugs are really important there. And a special diet, trying to avoid those foods that are more likely to produce this uric acid in the body. Musculoskeletal tumors. I'm skipping a couple conditions over to the musculoskeletal tumors. So we're talking about tumors of bone, cartilage, muscle. When I talk about a primary tumor, that's where the tumor originates. The secondary tumors spread from the primary site. The primary bone and cartilage tumors, when they do occur, fortunately, are usually benign, referred to as just osteomas or chondromas. Chondros, cartilage, omas, tumor, or osteochondromas, where it affects both the bone and the cartilage. even if the tumor is benign, it still will weaken the bone and likely cause a fracture. Now, I've used the term pathological fracture here. Pathological refers to disease. It's a disease process that causes the bone to break. That's a pathological fracture, as opposed to a traumatic fracture where the person truly has an accident or falls and breaks a bone. Pathological fractures are due to a disease process. Okay, a little bit about malignant tumors. Again, they can be primary or they can be secondary. Primary tumors account for over 85% of bone tumors in children, but are rarely seen after the age of 30. Males are affected more often than women. After the age of 30, if a person has cancer of the bone, it's probably traveled there from somewhere else through metastasis. Okay, the osteogenic sarcoma, the most common primary malignancy of bone. You know that malignancy means cancer. When I talk about just musculoskeletal tumors, a tumor can be benign, which is non-cancerous, or malignant, which is cancerous. The osteogenic sarcoma is cancerous. It's the most common of the primary malignancies of the bone. If it's going to occur, it's usually in people less than the age of 30, usually in children. Usually affects the ends of long bones. Treatment, chemotherapy, surgery, and you can see a great picture on the screen of a bone with osteosarcoma. And there's also a really good picture in your book of the osteogenic sarcoma. Ewing sarcoma usually involves the entire medullary cavity of the shaft. Radiotherapy, chemotherapy are the very best treatments there. The Ewing sarcoma often involves the pelvis and lower extremities. If someone's going to develop Ewing sarcoma, it's usually between the ages of 4 and 25. The tumor not only affects the bone, but it also moves into the other soft tissues and often metastasizes to the lungs. Again, if someone has primary cancer of the bone, that's where the cancer originated. It's usually going to be a child. Most commonly going to be osteogenic sarcoma, could be Ewing sarcoma. And then your book also describes briefly the chondrosarcoma. Chondro tells you there's cartilage involvement there too. It does grow more slowly than these other malignancies of the bone. The secondary bone tumors are carcinomas that have metastasized. So when an adult develops bone cancer, they'll usually find a primary site of cancer somewhere else in the body. Maybe they started with the primary of lung cancer, and the lung cancer metastasized or spread to the bones. The bone is a secondary site. And most likely bones to be affected by secondary cancers are the ribs, sternum, skull. They're very highly vascular and likely that cancer cells will be carried to that area. You see the words sarcoma and carcinoma on the screen. And in terminology, you should have learned about the difference. The carcinomas are the cancers that have developed from epithelial cells. So when those cancers metastasize, it's epithelial cells that are being brought to that secondary site, to the bone. So they're carcinomas. The sarcomas are the ones that are going to originate in the bone. The sarcoma refers to a cancer of bony tissue, of connective tissue. Now the muscle tumors They're not very common. They're almost always benign. If they're benign, they're referred to as leiomyomas or rhabdomyomas. The leiomyomas are tumors of smooth muscle. And the most common site for a leiomyoma is the woman's uterus. Leiomyomas. Rhabdomyomas are benign tumors of skeletal muscle. They're benign tumors, skeletal muscles, the voluntary muscles. Now, if a person has a cancerous muscle tumor, then those are referred to as either leiomyosarcoma or rhabdomyosarcoma, with the word sarcoma being present there. The sarcoma refers to cancerous tumor of connective tissue. The leiomyo being smooth muscle, the rhabdomyo being skeletal muscle. It's bad news with the cancer of the muscles. It's not very common, but the prognosis is very poor. They metastasize rapidly, and they are extremely difficult to treat. The most common site of metastases is the lungs. Okay, we're going to talk about osteoporosis, which is most common in women as a consequence of estrogen deficiency with menopause. A lack of estrogen promotes excessive bone resorption. We have these bone cells that are called osteoclasts that actually break down the bone and release calcium from the bone. When a person has a low level of estrogen, their osteoclast will increase in activity and break down more of the bone and release more of the calcium, which causes less bone deposits, which causes thinning of the bones. And the more the person has thinning of the bones, the more likely they are to have breaking of the bones. Osteoporosis, decrease in bone density, in the mass of the bone. It's a thinning and weakening of the bones, also called osteopenia. Same conditions. Penia is deficiency. And it is the most common of the metabolic bone diseases. Most common in postmenopausal women whose the level of estrogen has dropped. Good diagram here showing the young woman who's standing up straight, and you can see the measurement there. And as an elderly woman after menopause, after the level of estrogen has dropped and osteoporosis has progressed, she starts getting that humpback, that kyphosis, because her vertebrae are breaking down, because her vertebrae are compressing and breaking because of the disease process of the osteopenia. You hear of elderly women who commonly break their hip, and it's not that they fall and break their hip, it's that their hip breaks and then they fall. You can see a great picture of the hip here with the normal bone and the osteoporotic bone, and what the neck of the femur looks like there. It's this bone, I'm using my mouse to circle here. This is the femur, where the femur fits in this, it's a ball and socket joint of the pelvis, and it's very likely in this thin area of the neck of the femur, it's common for it to break when a person's bones become very brittle and thin. That's the hip fracture. It's asymptomatic. A person's not going to feel this process of thinning of their bones. They won't know it until they develop a pathological fracture. Again, pathological fracture, not traumatic. They're standing there and their hip breaks and they fall. It's not that they fall and the hip breaks. The hip breaks because of a disease process. And it's much more common that the fractures are going to occur of those weight-bearing bones of the pelvis and the femur and the vertebral column. Osteoporosis is easily diagnosed by a bone scan. And it's pretty common for bone scans to be performed on the postmenopausal women, especially those that have a family history of osteoporosis. The hereditary tendency is great. If a person's mother or sisters have osteoporosis, they're very likely to have osteoporosis also. And it is more common in sedentary individuals. The person that exercises more and uses those weight-bearing bones and muscles, they're much less likely to have the osteoporosis. Also, calcium intake. It is important not only when the person has reached that postmenopausal age, but when the girl is 20, 25, 30, 35, they need to be sure to take in enough calcium. Probably going to need calcium supplements, calcium and vitamin D. You cannot absorb calcium from your digestive tract unless vitamin D is present. Now, men can also develop osteoporosis. Let's not leave them out, but it's just so much more common in the women. It's also more common in people who are not using their bones and muscles. In bedridden patients, in bones that are immobilized, deterioration occurs and is referred to as disuse atrophy. Atrophy of the bones because of disuse, but it's still a form of osteopenia, which is osteoporosis. And physical therapy, that's the key as far as keeping those bedridden patients from developing the osteoporosis. Also diet, the calcium, the vitamin D. Estrogen replacement therapy may be prescribed, may be necessary. Also medications like Fosamax, and there's several medications like Fosamax on the market now. The Fosamax will actually inhibit the bone resorption, and it really makes a difference. I know that my mother was suffering from osteoporosis, and she had shrunk 3 to 4 inches and had started to bend over and all. She was taking Fosamax and estrogen replacement therapy, and it really makes a difference in strengthening the bones. Now we're going to look at 2 conditions, osteomalacia and rickets. Actually, it's the same condition. When osteomalacia occurs in children, it's referred to as rickets. And osteomalacia is softening of bones. Great picture of the kids here, that their legs are bowing, their leg bones are bending because their bones have softened. Malacia means softening, and it's due to a vitamin D deficiency. I mentioned a few minutes ago how important it is for calcium to be absorbed from the digestive tract. It's important to have vitamin D present. So a person must have vitamin D. Vitamin D, your body can form the vitamin D with sunlight exposure. Certainly at least drinking vitamin D fortified milk, taking vitamin D and calcium supplements. So important to avoid problems. And in children it's called rickets, in adults it's called osteomalacia. It's really the same condition. Adults usually do not have the bending deformities of the bones because their bones are already fully developed, but they'll develop muscular weakness, pain in the bones, especially the spine, the pelvis, and the legs. Treatment is about taking vitamin D supplements, adding vitamin D, calcium, maybe even calcitonin to the diet, exposure to the sunlight. Very important, especially for elderly people that are not so likely to get out in the sun. Okay, fractures. You probably all know a little bit about fractures. We're going to skip over a few pages here. Important abbreviation, commonly used, FX. And there's many different types of fractures. A fracture is a broken bone. A simple broken bone, a simple fracture, is when the bone breaks but there's no open wound in the area. A compound fracture is an open fracture. There is an open wound of the skin present at the fracture site. Great diagrams here showing the simple fracture with no open wound and the compound fracture where the skin is broken. And then the pathological fracture I described a few minutes ago when I was talking about the cancers of the bones, the tumors of the bones, or osteoporosis that are disease processes that cause the bones to break. Comminuted fracture, great picture there of a comminuted fracture where the person's bone has actually been crushed. There's splintering, several pieces of the bone present there. Great pictures in your book to review and see what these fractures look like. And you do need to know the differences in these types of fractures. Whatever the type of fracture, treatment is going to be reduction. Reduction of the fracture is to restore the bone to its normal position. To hopefully just manipulate the bone to the normal position. That would be a closed reduction where they do not have to do surgery, where they can just manipulate the bone back to the correct place. The open reduction is where surgery is performed. They actually have to cut through to put the bones back in the proper position. When they do that, they may also add internal fixation devices like screws and pins and nails. Take a look at the green stick fracture. I've got a copy of a X-ray on the screen for you showing the green stick fracture, where the bone is partially broken. It's partially bent on the opposite side. The green stick fractures are more common in children, and there's again a great picture in your book on page 306 of the green stick fracture, letter F. Colles fracture. The Colles fracture is of a specific bone. The Colles fracture occurs in the wrist at the lower end of the radius. The Colles fracture. A person's more likely to develop Colles fracture when they fall and they reach out to catch themselves with their hand, and the radius may snap there at the lower end. Certainly you need to read over all of the types of fractures described in your book. It's all important for you there, but I know that you can look at the picture and see the description in your book. For instance, in your book on page 308 is a description of the Lefort fracture, bilateral horizontal fracture of the maxilla. The maxilla is your upper jawbone, just above your lip there, part of your skull bone. Often results when the face is forced against the steering wheel in a motor vehicle accident. The Potts fracture is a fracture of the lower part of the fibula. Again, the treatment involves reduction, and the reduction may very well be, I've got to move back on my screen, sorry about that. And the reduction may very well be open. Good description under treatment. Treating the compound fractures, the fracture area, it's an open wound. It needs to be cleaned, debrided, reduced, put back in place, immobilized. Immobilization of fractures, a person may wear a cast or splint. And then there's good description in your book of the internal fixation devices, the pins, the wires, the rods, the plates. And then note the description of complications of fractures, a condition called compartment syndrome, where the circulation in the area is compromised because there's so much edema in the area. Non-union and malunion would be where the bones do not fit back in the proper position. Infection like the osteomyelitis. Okay, under strains and sprains, the strain is an injured tendon, muscle, or other tissue resulting from overuse, overstretching, or excessive forcible stretching of the tissue beyond its functional capacity. And the strains cause pain. The strains may be due to some acute trauma, or maybe due to some cumulative trauma, something that you do over and over again. Treatment usually is about putting ice on the area, resting the affected area. And then a sprain is an acute partial tear, a tear, not just a stretching, but a tear of a muscle, a tendon, or a ligament. May also involve damage to blood vessels and nerves. The sprains are usually more severe than the strains. Treatment is kind of the same. It's putting ice on the affected area. Ice reduces the inflammation and edema, resting the affected area. So it takes a while to get over the strains and sprains. It takes even longer to get over the sprains, 4 weeks or longer if it's a serious sprain, which with damage to several structures inside the joint. I skipped over dislocation. Dislocation, the joint will separate, displacing the bone from its joint. I've moved on to adhesive capsulitis. Great picture here showing what's referred to as frozen shoulder syndrome. The area of the frozen shoulder, it's painful. The person's usually had some injury and they stopped using that shoulder. They said, it hurts and I'm not going to use it, I'm not going to move my arm, I'm not going to lift my arm. And the more they did not use the arm, the more the arm became more painful when they tried to move the arm again. Adhesive capsulitis, a condition in which a shoulder is significantly limited in its range of motion as a result of inflammation, scarring, thickening, and shrinkage of the capsule. Etiology: caused by inflammation of the capsule of the joint, usually begins after a slight injury or a minor problem such as the bursitis that I talked about a few minutes ago, or maybe even tendonitis, something that prevents the normal use of the joint, and they don't use the joint, and the more they don't use the joint, the more they can't use the joint. And eventually it may come to the time that they're going to have to have general anesthesia so that the doctor can forcibly move that joint. So the doctor can forcibly break the scar tissue there and allow for movement again. That's in very severe cases. Generally, the person may just have physical therapy and some exercises to assist them with their range of motion again. Analgesics again for the pain. Anti-inflammatory agents is necessary, whether they're non-steroid anti-inflammatory, or they may have to have the steroids, which are certainly more powerful, but also carry more risk. Okay, skipping over a couple of conditions to the torn meniscus. Torn meniscus, usually a sports injury, usually caused by a quick twist of the knee, whether it's in basketball or football, or the person may not be doing any type of sport and actually tear their meniscus. I want you to take a look at the pictures in your book to compare the normal knee with the knee that has a torn meniscus. There are two menisci in the knee joint. The larger and more restricted medial meniscus is more restricted in movement, so that's the one that's more likely to tear or be injured. The anterior and posterior ligaments may be torn at the same time. So a person can have torn meniscus and a tear of an anterior ligament or posterior. The major symptom, of course, is going to be pain. The person may actually hear a snapping sound when they bend or try to extend their knee. When they try to put any weight on it, it's going to hurt really bad. The first thing is immobilization and ice application. The person may have to have surgery, may have to perform what's referred to as a partial meniscectomy, which is ectomy, removal of the meniscus, just partial removal. And it's usually performed arthroscopically, which means that it's performed through a scope. There's a great enrichment in your textbook on page 318 where they describe the arthroscopy, where the structures of a joint are viewed through a special scope. And that scope has optical fibers and lenses, and a physician may just look around, do kind of an exploratory arthroscopy. It's more likely, though, they're going to do some procedure through that arthroscope. We have the MRIs and the CAT scans that can be done to show the joint structures, and then repairs usually performed through an arthroscope. And then rotator cuff tears. Rotator cuff muscles stabilize the head of the humerus in the socket. Tears in the tendons of this rotator cuff produce an immediate snapping sound. It's like the person knows when they've done this, and they have acute pain, and then they're unable to lift their arm, unable to abduct the arm. The tears may result from trauma, an immediate trauma there. More likely they're going to result from some cumulative trauma or degenerative changes of that shoulder. Now, the steroid injections increase incidence of tears because a person who receives the steroid injections, if they have shoulder pain or shoulder injury and they're receiving those steroid injections, that reduces the inflammation and pain, but the injury is still present. The reduction in inflammation just kind of masks the symptoms, so they're more likely to use that shoulder and cause further damage to it because it's not hurting so bad because they've had that steroid injection. Treatment, painkillers, the analgesics, the anti-inflammatory agents, and the acute tears are going to have to be repaired. And then the person is going to have to go through a period of time of immobilization of the shoulder and then extensive physical therapy to regain use of that affected arm. And this concludes the lecture for Chapter 7.